So I think the issue of when to use CDK4/6 inhibitors is a really interesting question. I think there's kind of two camps out there. One camp who sees the benefit of these first line and wants to give them as early as possible. And second, those who say that they have a patient population that some patients do really well on just endocrine therapy alone, and you really can reserve the CDK4/6s to be used second line. I think it's important to really look at the data here. In my opinion, at least, I think that if you look at the Paloma data, if you use CDK4/6 in combination with letrozole in the first line setting, you're really looking at a 25 versus 15-month progression-free survival. In the second setting with fulvestrant, you're really looking at a 10 versus 5-month progression-free survival. So if we add those up for the two different situations of patients, whether they use it first line or whether they use it second line, you're really looking at a 30-month differential versus a 24-month. So you're really gaining about 6 months in progression-free survival over the first two lines if you do use CDK4/6s up front first line. So at least in my practice, I do give CDK4/6s first line with letrozole unless I have a good reason not to. I think the other important thing to consider about these drugs is the starting dose. I always do start at 125 milligrams. I don't routinely start lower. Obviously, the incidence of neutropenia is quite high, and I think it's something we have to watch out for. But at this point, I don't think we have evidence to start anyone lower prophylactically.